because again, some people are on phone numbers and stuff. So, okay, so let me just get this to
I have a
record.
question.
Go ahead.
Oh, it was showing something about pediatrics. Why was it showing pediatrics if
No,
this is geriatric?
I will, hold on. Oh no, I think it is recording now. Let's see.
It is recording now.
Yeah,
Okay,
it says
okay,
recording.
fine. So we're going to do regular cardiac in a second, but what I thought is this is the latest thing coming out with COVID, is that for a while they were saying it doesn't really hit children, but they're having cases now where children are developing this Kawasaki disease. So I thought we just talk about it. The state put out a advisory today on it. So I thought we just talk about it. Nobody has seen it in Rockland County. I think there's been some cases in New York City, but I thought it would be something a little different to talk about, and then we'll go into the regular cardiac that we always kind of review when we do it. Okay, so we know that one of the things with the COVID is that there's a massive inflammatory response in the body, and that tends to be what's killing the patients. And that's why the initial treatment, which was CPAP and BiPAP and vents, didn't really seem to do a good job. Okay, and patients that were put on vents tended to linger on a week or two and then die. Now they're moving towards suppressing this inflammatory response in the body, and you've heard of some different drugs that are coming out and stuff like that. So what Kawasaki disease basically is, well, obviously it's a disease that was predominantly seen in Japan and Asia. What's that? I'm going to mute everybody, so if you have a question, you can just unmute yourselves. But it was mainly seen in Japan. Very few, cases in the United States, but mainly it was seen in, or I should say, very few severe cases in Japan, in the United States, but mainly seen in Japan. So what basically happens is it's an immune response, an inflammatory immune response in the blood vessels, and for some reason, it particularly is in the blood vessels of the heart, the coronary arteries, and kids are getting aneurysms in their coronary arteries of their heart. So right now, I think they said, in the United States, it's like 50 cases they're attributing to COVID, but it's like climbing substantially every day. There's like, first it was one case, then it was two cases, so it's climbing. So they put out an advisory. There's no way for EMS to really diagnose this. I'll talk about the signs and symptoms and stuff. There's no way for EMS really to diagnose it in the field. It requires blood work and everything like that. But just to have a suspicion, now, if you had a situation where the kid had a previous diagnosis of it, and the parents were telling you they think it flamed up again, started up again, then that would be a situation where really they need to go to a pediatric hospital. So for you in Orange County, I would say, where you guys are, it's going to be, either Albany, Hackensack, or Westchester. I don't know what's the closest, hospital for you, because there's nothing that's going to be done for these kids in a non-pediatric type of hospital. Okay. What's that?
Hackensack.
Hackensack is closest. Okay, it's actually an excellent hospital. Okay, so this PowerPoint here, this thing that was put out, is I pirated some of it from Seattle Children's Hospital, and there it was about a 7-year-old presentation. So it wasn't specifically on COVID, but there's a lot of good pictures and a lot of good information and stuff like that. So the inflammatory response is throughout the whole body. And then in some patients, it localizes in the coronary arteries of the heart, and they develop aneurysms and stuff. So I'll show you what it kind of looks like. Okay, so 250 to 300 per 100,000 children in Japan. Okay, and in the United States, around 20 per 100,000. So up until COVID, it wasn't a lot of patients. Okay, now what they're saying that in Seattle, 70% of these patients that had Kawasaki disease were not Asian. Right, so that's in itself a little concerning when you expected that it should be affecting more of the Asian population. Okay, so the diagnosis is that basically they have a fever for greater than 5 days. It's typically over 100, 101 degrees, and they have 4 of the 5. And I'll show you what all this looks like. So non-purulent conjunctivitis, which means normally you see conjunctivitis being infectious and there's a discharge. So in this case, the blood vessels, again, it's an inflammatory response in the blood vessels, and you see it very easily in the blood vessels of the eye. Just like sometimes you've gone, you've heard of people who went for an eye checkup, and the doctor said, oh my God, your blood pressure must be through the roof, because he's looking at, the pupil, not the pupils, the arteries in your eyes, and he sees them greatly dilated and stuff. So the same thing. Okay, their lymph nodes, okay, especially in their neck, get enlarged, and they almost have what looks like a swollen neck. Okay, they get a red rash throughout their body. On their tongue, they get this very distinctive, almost looks like pus sacs, like little tiny pus pimples on their tongue. Okay, and then in the extremities, and this is an interesting thing, this is how it first kind of came out. There were kids that were going to the hospital and looked like they had frostbite on their toes, and they had the skin sloughing off and stuff like that, and swollen toes, and yet there was no exposure, environmental exposure to cold. So then some people were saying it was a fungal infection, you know, and they were putting them on, you know, antifungal creams. It wasn't getting any better. And this is really the first thing that I guess the doctors started keying in on, like, why were we seeing all these kids who, you know, had this, you know, the situation going on in their toes. Okay. So that's the main things that you would look at. Okay. It's higher in children that are less than 5 years of age, but it can happen, you know, up until early adulthood. Okay, so you know, even in older kids, it can happen. Often misdiagnosed in older children because it's, you know, again considered to be more of a younger child. So this is the conjunctivitis, and I don't know how well it's coming up on your screens and stuff, but you
It's
can see
not.
it's not.
Yeah, I put it in the chat, Frank. Some of us can't see any slides.
Huh. Hold on.
I think none of us can see any slides.
Okay. Well, let's see. Hold on.
Thank you.
Let's see what's happening. Can you see it now?
Yes.
Yeah.
Okay. So let me.
Yes, I thought it was just me.
No, so please. Okay, so let's just go back. This was the slide where I was talking about the various different, you know, signs and symptoms that you see, right? So we talked about all of this over here. Now we're going to see actual pictures of it. Okay. So again, this was the non-purulent conjunctivitis. Okay, and you know, where you get the basically red eyes and stuff, and then also at the same time this happens, they usually have going on in their mouth. Okay, so here again the eyes. And so, you know, this could look like somebody who's just tired. Okay, so this is what happens around the lips and the tongue. And I'm sure that would be, you know, making a parent, you know, either rush them to the pediatrician, which again is going to be hard now because the pediatricians really are not seeing patients. So again, it can trigger a 911 call. Okay. Okay, so again, they get this reddened and the skin sloughing type of situation over here. Okay. Same kind of a thing that was on the tongue. Okay. Swollen extremities. Okay, and I think I had a picture of the skin. So, and this is all, again, an inflammatory response in the blood vessels, right? So that's why you're seeing it. Okay, they get swollen glands in their neck. So their lymph nodes are all swollen over here. Okay. So, you know, as far as some things they're thinking, and again, now with COVID, the viral concept that there may be a trigger or something that's causing it. So this inflammatory response, and again, in this case, it would be the COVID. Okay, so that's, you know, one of the things they're talking about. Okay, so 7-day history of fever with this one says 2 to 3, but I usually say 4 to 5. Okay, in a child, okay, under 6 months, 7-day fever, and then they need lab evidence, okay, of why it was there. And I took out the slides that talk about the different lab tests that they would perform on these kids. Okay, now there's one, I guess, worse type situation of it, which is a child that develops hypotension, okay, from it. So again, it's an inflammatory response. The blood vessels are dilating and they drop their blood pressure. So it's a type of distributive shock. Okay, so here they would drop their blood pressure. So obviously they would have an altered mental status and everything else that you would see with shock. This is a angiogram of a child's coronary artery, and that's the aneurysm. Can you see my cursor sliding across it?
Yes.
Okay,
Yes.
so that's the aneurysm right there. Now, obviously, with an aneurysm, there's always the potential that it could burst, and that's rare in this situation with the kids. It's just that they then develop problems the rest of their lives as far as their, you know, their cardiac condition. Okay. Now, treatment is they give them gamma-globulin, just like you would get when you had mono and stuff like that, because again, it's a massive inflammatory response. Okay, so that's one treatment. The other treatment would be aspirin, because whenever you have aneurysms, there's always a risk of clotting. You know, when we talk about like a abdominal aortic aneurysm or anything like that. One of the things that you could see when you have an aneurysm, right, is, so let me backtrack. So, what is an aneurysm? So an aneurysm is that arteries have 3 layers, an inner, middle, and outer layer. And that something has caused the inner layer to erode so that blood could start working itself, okay, between the inner layer and the middle layer and start making what they call an artificial lumen. So the lumen is the part that the blood would go through, the center part of it. So now it makes a second lumen. So it starts to spread that and start tearing it. That's when it's called a dissecting aneurysm. And that's why they say that people have the tearing pain. That's the blood vessels, the walls of the blood vessels separating. Okay. So now when you have that blood that's going into that false lumen, it has, it can only go in, say, an inch, right? Or, hopefully not more than that. So anytime blood flow becomes stagnant, what happens is it can clot. So one of the typical things you see with abdominal aortic aneurysm, if they throw a clot, is that one leg will go numb and cold. So it's not necessarily that the aneurysm is causing, it's the clot that freed up from the aneurysm that's going down, into the iliacs, into the femorals, down into the leg and causing the occlusion. So these kids have the same issue here. And in here, it could actually cause a heart attack because if you go back to the slide, right? So, if you now throw a clot out of here and it goes further down and lodges, okay, it's going to occlude blood, which is a heart attack, right? So this whole section now of the myocardium is going to be deprived of blood. And remember, at this age, we're talking, they don't have what's called collateral circulation. If this was an angiogram of, most of our hearts, probably what you would find is that the inside of the arteries are kind of narrowed from calcium and from fat. So if the body, senses that you're not getting enough blood flow to a section of the heart, it grows what's called collateral circulation, which means it grows other blood vessels in the area. That development of collateral circulation doesn't usually start happening until you're in your 50s and 60s, which again, you've heard of the 80-year-old who tells you he had 4 heart attacks and he still, plays tennis. But you've heard of the 20-year-old or 30-year-old had a heart attack and died from it. Then the difference is that when that older person occluded a vessel, he had a lot of collateral circulation because his body had time to develop it. When the younger person had the heart attack, he had no, or she had no collateral circulation. So when they closed off that vessel, there were no other blood vessels in the area to supply that part of the myocardium with blood. So that's the danger now with this kid is that, obviously at this young age, he doesn't have it. So that's one of the things. So they go on aspirin. They actually stay on aspirin for quite a while. Sometimes months. They go on aspirin. Okay. And they had here that, ibuprofen actually does the opposite, would make it worse with them. And they stress that, pretty heavily with parents because not a lot of people have aspirin in the house anymore. A lot of people have Tylenol, have ibuprofen, and stuff like that. So they stress that a lot. Okay. So again, some things, that the parents and the child have to face. So, 5 to 7 days of fever at home, a very unhappy, irritable kid, a lot of sleepless nights, both for the patient, the child, and the family. Okay. A lot of doctors, they have to go to specialists. And for a lot of people, that means traveling, right? And difficult diagnosis. A lot of times they think it's infectious, not, immune response. So they put them on antibiotics. And obviously when people are on antibiotics, there's other side effects with the stomach and stuff like that. Okay. Again, from the standpoint of the parents, right? It's a mysterious disease. They can't really give them a complete answer that they're going to be fine because it can flare up again later in life. There's a high potential for heart disease. Okay. The medications they have to take, okay, require the dosing, to be done, the administration to be done for long periods of time. Okay, and then again, the parents in the family would obviously expect, like most of us would, right, that there's a treatment right away for this and that the child is going to go home. So it's definitely a very stressful situation. Okay, some things that they're told, right, so that their behavior will not return to normal for 4 to 6 weeks because they're so irritable, sleeping's a problem. Okay, and that their hands and feet can have that sloughing off of the skin. Okay, and the skin will be very sensitive to cold, very sensitive to sunlight for quite a while and stuff like that. Okay, the other thing they'll instruct them is that they should not be getting any live immunizations, and it's not that the immunization is going to cause a problem. It's just that because they're on these immune response types of medications that the immunization will actually take, so they won't develop antibodies. So that's the reason why. But if it's a inactive one like flu, then it's fine for them to get it and stuff. And again, aspirin is the main drug to prevent the clotting. Okay, so they really stress that. Okay, and then The other issue would be, the kids that have the bad version of it, especially if they have the shock version of it, okay, they're going to have a debilitated heart for the rest of their lives. Because of that, they're going to have restricted activity. They're probably going to have to be going under procedures because that or they're probably going to have what's called coronary artery bypass surgery to cut out that part with the aneurysm and graft in a fresh piece. And, I mean, that was the treatment years ago for heart attacks. So it's not an uncommon procedure, but it's just that nowadays with intravascular treatments like stenting, it's not so common to be done anymore. I wonder if they can float like a, like now with aneurysms in the stomach and the chest, they actually float what looks like a piece of hose. It's usually a couple inches longer than the aneurysm, and then they can press a button and the hose kind of expands, and now the blood starts to go through the hose, so it takes the pressure off the aneurysm, and the aneurysm kind of collapses back down onto the hose and grows into it and stuff. So I'm not sure if they can do that in this situation because, you're talking tiny arteries, coronary arteries and stuff like that. Again, they're going to have to be anticoagulated, and statistically, children who have Kawasaki disease die young. They die in their 30s and 40s. So then one thing I just saw that I thought was interesting, there was some tie in between the intake of soy and the risk of Kawasaki disease. I didn't have time to read the articles. I don't know why. And there were some places that disputed this. So I don't know it's 100%, but that was just one of the things that I saw there. Okay. So that's basically what I have. I don't know if anybody's, obviously I don't think anybody's seen this, but I don't know if anybody's heard anything about this or anything like that. Okay. Are the slides still up there? Still showing?
Yes.
Okay. So any
Oh, that's a good one.
what's yeah, that was my old days. Unfortunately, don't have the time anymore. So, but soon I'll have the time. So, okay, so can you see the collaborative protocol update now on the screen?
Yep.
Yes.
Okay. So any questions on the Kawasaki? I mean, if you've been reading the newspaper or listening to the radio, TV, or anything, I'm sure you've been hearing about it. But
You can't miss it on TV right now.
oh, really?
They're up to like 60 kids, I think.
In the New York area or the country?
I guess so. I'm not saying, I don't know if it's New
Okay.
York or the whole country.
Right. I don't know if you remember, but
Related to,
go ahead.
It is in the New
related
York
to
area.
allergic reactions. Is your body having?
No,
You
it's an
have
inflammatory response. So the thing that's killing a lot of these COVID patients is, yes, it's respiratory, but it's not respiratory like a pneumonia. So what's happening is that when you have this massive inflammatory response, there's a substance released in your body called cytokine. And it's an inflammatory chemical that's released. And what cytokine does is it changes the permeability of the walls of your blood vessels. And you know that capillaries, right, the smallest blood vessels, that's the ones that nourish the cells. So they have to be permeable, right? They're your only blood vessel that is permeable. And the reason they have to be permeable is they have to let water and sugar and oxygen leave the capillaries and get into the cells to feed them. And then they have to be able to accept the carbon dioxide and other waste products to remove them. So they're what they call permeable. What happens when you have a lot of cytokine, and the actual term is a cytokine storm. So when you have this massive secretion of cytokine, okay, what happens is the permeability greatly increases. And now the plasma, which is the fluid portion of your blood, freely flows out of the capillaries and flows into the alveoli, and they drown. It's called ARDS, acute respiratory distress syndrome. So everybody was thinking like, whoa, let's just put them on a vent. Tube them, put them on a vent. We'll have that higher pressure. It'll keep the fluid out of their alveoli. And it didn't work. It's not working. So what they're going now is the other way, which is suppress the inflammatory response. And by suppressing the inflammatory response, they seem to have a better handle on it. So, I'm sure you've all heard of patients, were put on vents and they languished on a vent for, a week, 2 weeks, and then subsequently, passed away. So it seems like now more of the treatment is going towards, again, suppressing that inflammatory response. So it's not really allergies. It's more of it's way beyond that. It's a massive, and that's why they're saying younger people, right? You would think that, with this COVID, that the only people who should have been dying is people in their 70s, 80s that had comorbidities and stuff like that. And it did hit that population very hard. but you also know, you've all heard, or God forbid, you know someone personally that passed away and was young and healthy. I mean, I had two I wouldn't say close friends, but two friends that died they were both in their 30s, and part of the problem was that they were taken to, local community hospitals, and, they languished being intubated on vents there for a week or two before the family decided to move them someplace else. And by then it was, they went to renal failure and it was too late. But, that what happened with those people is they had a massive inflammatory response. And at those hospitals, all they were looking at was, oh, their pulse oxes are low, so let's intubate them. Not trying to say why are their pulse oxes low, what's going on with them and stuff. Now, it's not to say that some people did not die of secondary pneumonias. That was much more common in the older population. But the younger, healthy ones that have a healthy immune system, that's when they have the cytokine storm, and that's what, and that's what they're even attributing the deaths of the people in 1918, right? Because this is what we're going through now is being compared to what they called the Spanish influenza in 1918. And it wasn't the Spanish influenza, it was a worldwide influenza. It just got the name of the Spanish influenza because in 1918, we were still in the First World War. And the vast majority of countries had censorship of the newspapers and media. Spain was neutral and they didn't. So Spain was the first country that actually published that all their citizens are dying, and therefore it became called the Spanish influenza. But what they did is they took lung tissue samples from a fort in the Aleutian Islands, and it was a military fort there to protect us from Russia. And this is 1918, right? And what happened is they got a resupply shipment of food and fresh soldiers, and there was a logbook. Every hour the officer on duty wrote in this logbook, and up until that ship came, there were no sicknesses, right? Nobody was sick, everybody was healthy. And about 7 days after that ship discharged the new soldiers and food and replacement stuff, people started getting sick. And it took about 45 days for that. I don't know how large of an outpost, but it took 45 days for that outpost to get wiped out from the Spanish influenza. So what they did is those bodies, the first people who died, they were buried in what they call permafrost, which is permanently frozen ground. So they were perfectly preserved, and it was very dry air. So they were able to go, and this is back when we had SARS and that one bad influenza a couple of years back. They went and actually exhumed the bodies and took lung biopsies from them and kind of matched it to the different viruses that were floating around at the time. And it's not an exact match, obviously, but they think this was also the issue with, again, young healthy soldiers, right? Why would a young healthy soldier succumb to the flu? And that's what they think is happening, is this is over immune response type of thing. Okay, so any questions on any of that stuff?
Yeah, will it be on the test?
No, nothing on Kawasaki is on the test except your version of it, Art.
Thank you.
Art, your test went up to 100 questions now. So. Okay, so let's talk a little bit about our routine cardiac stuff, okay, and how it affects us and the geriatric population and everything. So we're going to talk about a bunch of different medications that we're allowed to use when we treat those patients. So let's just make sure we know, what's the right way to administer medications, because the ability for us as EMTs to administer medications is really what separates us from people who learn first aid, right? Because I mean, a lot of what we learn as EMTs is, basic first aid, splinting, bandaging, and stuff like that. The difference is that you are allowed to administer medications, and with that, ability becomes a lot of responsibility, because we know that we can hurt patients by giving them the wrong medications, or the medications the wrong way and stuff. So they always have what they kind of talk about, the rights of drug administration. Now, a lot of this pertains to nursing and not us, and we'll talk about that. So obviously there should be no allergies to drugs, okay? And is there any medications that we will be talking about tonight, right, for the cardiac patient that we have to worry about allergies?
Aspirin.
Aspirin. So you already know one answer. Art, you already know one answer, okay? So we really have to do a good job in asking patients, are they allergic? Did they ever have a problem with aspirin? Now, when you say that question, you open yourselves up to some problems, because we know there are people who are taking aspirin for arthritic pain. And what happened? They didn't have an allergic reaction, but they had some bleeding in their stomach. Okay.
Stomach.
Yeah. Let
Right.
me just mute everybody. Let me see where you do that now. No. I know there's a way to mute
No.
everybody. Let's see. Oh, here it is. And this is muting me. Let's see.
We could still hear you.
Yeah, no, I'm trying to mute you, but I can't see it. How to do it. There's a lot of background noise. Okay. For some reason it disappeared. Let's see. Okay. Okay. So going back to what we're talking about now. So with the aspirin is that they may have been taking the aspirin because of arthritic pain, and then they developed some problems with their stomach. They had some bleeding and stuff like that. And once that happened, the doctor told them you should never take aspirin again.
Yeah.
So now we go and they're having, chest pain indicative of an MI, and we want to give them aspirin. So we tell them, we're going to give you some aspirin, and they say, no, my doctor told me I can't take it. So you have to then ask them, why did your doctor tell you, not to take aspirin? And if it was because you had some bleeding in your stomach, the couple of aspirin that we're going to give you tonight is not going to start you bleeding again. Because the dose of aspirin we give them for a heart attack is half the amount they would have taken if they had, I don't know, arthritic pain. So they would have probably taken 650. We're giving them 325. So it's a very low dose of aspirin, and they shouldn't fear it. But obviously, you have to get informed consent from a patient before you can give it to them. So you have to tell them what you're doing. So if they totally refuse it, then you can't give it to them, and you just document that you wanted to give it to them and they refused it. Okay. Now, again, some of this other stuff, the right person. So again, in a hospital, 2 patients in a room, they need to make sure they're giving it to the right person. For us, it's pretty rare that we're going to have multiple patients at this, that we're treating at the same time, unless you have some kind of field hospital or something like that. But again, make sure it's the right patient. Again, most of the times we're only giving 1 drug at a time, so that's not a big issue. But again, you would want to make sure you're giving the right medications. The big thing I see with here is the albuterol, that comes preloaded, is packaged the exact. There's another drug called Atrovent, ibuprofen, which is when the paramedics mix 2 in a nebulizer. They're packaged the same exact way, and the difference is that one has an A on the top of it, and it's very hard to see. If you remember those, I'll show you a picture later. One has an A on top, that's for the albuterol. The other one has an I on top, but they're packaged exactly the same. And I can't tell you how many times, if I go into medication bins, I see people, that are not paying attention, and when they're throwing medications in, they mix them up. So it's important to look at that. Now, you would only have albuterol, but let's say somebody decided to restock at the hospital, and it looks the same, and they grabbed it. So I'll show you what that looks like in a second. Okay, so right dose. So again, you need to know the right amount of the medication, and that is on a test, right? So in New York State, for aspirin, we're giving 325 milligrams. Some books talk 160 to 325, but our protocol says 325, okay? And then again, right time doesn't really pertain to us because it's going to be the time that we need to treat the patient, but in the hospital, patients take medications on our schedule, okay? Some people include for the right time the expiration date, so obviously we should not be administering expired medications. Right route, obviously being important, okay? And then the right documentation. So documentation, very important to protect us and justify what we're doing. So if you're gonna give a patient aspirin, let's say, right, there should be a clear documentation that there's, what anybody else would assume to be a heart attack, just like you are, right? That a patient suffering what appears to be a heart attack, okay? That you asked about allergies to aspirin, okay? That you document the right dose. And then what's important also, is for most medications, a set of vital signs. The only one that the protocol technically says you don't have to get vital signs or consent actually for is in anaphylaxis, is when you're giving epi. But everything else, it really says that you should get a set of vital signs and a informed consent, okay, except for epinephrine and anaphylaxis. Then you want to document the response to the medication, right? In other words, did they stay the same? Did they get better? Did they get worse? And if time permits, a repeat set of vital signs. So aspirin, you're probably not going to see a change in their condition. But let's say we're giving somebody nitroglycerin. If you gave somebody nitroglycerin, they said to you, my pain was a 9 out of 10, and now they say the pain's only 7 out of 10, that would be a positive response and would lead you to think probably more that it's not a heart attack and more like it's angina type of pain. So documentation, very important. And what I always think to myself is that if somebody is going to read this 3 years from now, because that's the average time it takes a lawsuit to, make it into where people start reviewing stuff. If somebody's going to read this 3 years from now, are they going to understand why I did what I did tonight? Okay, and that's also why you want to take the time to, avoid, well, back in the day when we wrote it, to write it neat, but now that you're using a computer, to make sure, there's no misspellings. If you're, taking care of the patient's right arm, that you actually, it is the right arm and not the left arm. All those little things that they try to pick apart and make you look stupid, if it ever goes to an actual jury trial. Okay, so an indication is the reason why we use a medication, right? So nitroglycerin, the indication would be somebody having chest pain. Okay, oxygen with somebody having chest pain and their pulse ox is below 94%. What else do we have? Aspirin, again, somebody who you think is having an acute myocardial infarction. So an indication of why we would use it. A contraindication would be a reason that we couldn't use it. So if somebody had a history of anaphylaxis to aspirin, then obviously that anaphylaxis would be a contraindication to giving the aspirin. Okay, the action is what it does, and we'll talk about that with each medication, right? Side effects. So we know, let's say, for instance, nitroglycerin, right? A normal side effect of nitroglycerin would be that a patient gets a little bit of a headache. Okay, a bad side effect of nitroglycerin would be that you drop their blood pressure and they syncopize. So there's different levels of side effects. And therapeutic level refers to that you have to get a certain amount of drug on board for it to do what it needs to do. So probably 325 milligrams of aspirin is more than you need to get a therapeutic level on board if the patient weighed 110 pounds. But they want to pick one dosage that's going to cover the vast majority of patients. So they're probably shooting more towards the patient that weighs between 150 and 200 with 325. There was a time where we actually titrated it. We gave 2 if they were under 150 pounds, and we gave 3 if they were between 150 and 200, and then we gave 4 if they were over 200. But they just now decided that 325 is a good number to cover all your patients. And again, that 325 is not a dangerous dose in the vast majority of patients, because it's half the dose some people took when they had a toothache. Okay, so cardiac related chest pain. So we have a couple of different conditions that I put up here. Okay, so angina pectoris. So angina pectoris just means pain in the chest, right? Pectoris is your pectoral muscles, your chest. So versus the acute myocardial infarction, which is the true heart attack. So what happens? So both of those, angina and acute myocardial infarction, the culprit most of the times, unless it's something exotic like this Kawasaki, the culprit most of the times is what we call coronary artery disease. Okay, so we all have coronary artery disease unless we really, really, really have a healthy diet, and a healthy diet would be, a lot of leafy green vegetables, not a lot of fatty foods, not a lot of red meats and stuff like that. Definitely not a lot of processed meats. Okay. But we all probably have some coronary artery disease. So what is coronary artery disease? Coronary artery disease means that you have fat deposits inside of your blood vessels, okay? And you have calcium that's infiltrating the walls of the artery. So we know that arteries have muscle to them, and they have the ability to constrict and to dilate. So most of the times when we're doing any type of exertion, we want our arteries to dilate so we can get more blood through them and keep the muscle perfused, right? The muscle needs to be, all cells need to be perfused with oxygen and sugar to work. And if they don't have that oxygen and sugar, they revert from aerobic metabolism. Metabolism is the burning of sugar and oxygen to make energy. So they revert from aerobic metabolism, okay, to anaerobic metabolism, which is making energy with not enough oxygen. So in both situations, they make energy. Obviously, they make a lot more energy with aerobic. But the bigger product is that the waste products, the bigger problem, is the waste products. So when you're making good energy with oxygen and sugar, aerobic metabolism, your byproduct is carbon dioxide and water. And you can get rid of those, right? You exhale the carbon dioxide, you urinate out the water. Actually, you reabsorb most of the water. And use it, okay? The problem is that when you have anaerobic metabolism, the waste product is something called lactic acid. And you've all had a situation where a muscle in your body reverted to anaerobic metabolism. You were, I don't know, exercising, you were screwing a light bulb above your, above your head, and all of a sudden your arm got tired and shaky. You were walking real fast and you got a pain in your side. That's all lactic acid, right? When lactic acid gets into a muscle, it gives a burning, painful sensation. The muscle doesn't work well, you start shaking and stuff like that. When somebody's having a heart attack, right, that chest pain they feel, even though the test answer is always lack of oxygen, the lack of oxygen is leading to the anaerobic metabolism, which is leading to the lactic acid. So the pain somebody feels is actually the lactic acid. So in both angina and acute myocardial infarction, because of this coronary artery disease, this fat And the calcium doesn't allow the blood vessels to dilate. It stiffens them. The old term for angina that people used to call it was hardening of the arteries, right? They don't dilate. So when somebody runs for the bus or gets into an argument and they need more blood getting to their heart, their arteries can't dilate, plus they're clogged up a little bit from the fat. So now what's the difference between angina and acute myocardial infarction? So the etiology most of the time is the same. There are some rare types of angina and heart attacks where there's spasming of the arteries and stuff like that. But, those are very, very rare, okay? But, for most of us, it's the garden variety angina, garden variety heart attack, okay? So what's the difference between the two of them? Well, one is episodic, where there is a mismatch between the amount of oxygen the heart needs at any given time versus the amount of oxygen it can get because of this coronary artery disease. And that's angina, right? So what happens? You climb up 5 flights of stairs, okay? So now all of a sudden you're pounding away, you're getting short of breath, right? And you get pain in your chest. So what happened is you increase what's called your myocardial oxygen demand. So your myocardial oxygen demand is how much oxygen does a heart muscle need at any given point. So right now, sitting here, we need very little. If we got up and started exercising, we'd need more. And this person started walking up the stairs, they needed more oxygen to get to their heart because their heart was working harder. Because of the coronary artery disease, they couldn't get it. So now all of a sudden, they get lactic acid. They revert to anaerobic metabolism. They get lactic acid in their heart, and they get chest pain. And hopefully they're intelligent and they sit down, and within a couple of minutes, things should equalize because by sitting down, they decrease their myocardial oxygen demand, and the pain should start going away. A lot of times that doesn't happen because they get scared. And when you get scared, you release adrenaline. And what does adrenaline do to the heart? It makes it work harder, so you need more oxygen. But if they didn't get scared, if they knew what it was and they knew what to do, it should actually get better without us even getting there. Now, once they get this diagnosis, or once they go to the doctor because they had these symptoms of angina, they obviously get a stress test, and they fail the stress test. They get a cardiogram done, cardiac angiogram, done, where they go and look in the arteries to see if there's any blockage, okay? And then they see that there's certain arteries that are narrowed. Sometimes they may stent them open and look, try to develop more, if there's certain areas that are very narrow, they can stent them open. But a lot of times they just manage it pharmaceutically, and they'll give them medication to slow down their heart so it's not as taxed, and they'll give them nitro as kind of an emergency medication, nitroglycerin, that if they develop this chest pain, they can take nitro, which is a quick acting smooth muscle relaxant, right? So that's its action. And since your coronary arteries are smooth muscle, it relaxes them. Now, interesting thing about nitro is that it's a non-selective smooth muscle relaxant. So you have smooth muscle in a lot of different places in your body. So you have it in your lungs, in your bronchioles, you have it in your blood vessels, you have it in your GI tract. So when you give somebody nitroglycerin, it can make their stomach feel better, it can make their breathing feel better, it can make their heart feel better. So there's multiple things that could happen with it. Now, we give it obviously for its relaxing of the blood vessels. It doesn't just relax your coronary arteries. So that's the bad part about it. It relaxes all the blood vessels in your body. So that's why we can drop people's blood pressures with it and make them faint, make them syncopize. So that's what happens with the angina type of patient. So now what happens? They have this attack, this angina quote attack. They call 911. Maybe they have nitroglycerin. Now the problem with nitro that a patient possesses is that it probably costs them some money unless they're on Medicaid, right? Cost them some money, and they never had an angina attack before. The thing expired, and they said, I'm not going to refill it because it cost me a lot of money. I never had to use it. So now they have their angina attack, the first one in 5 years, and they go to take that nitroglycerin, and they open it up, and what? It's not potent anymore. So the bad thing about nitro, especially the little white tablet nitro, is the potency is horrible. The spray one lasts much longer, but the spray one is like almost $500-$600, where you can get a bottle of those pills for $50. So a lot of people that have high deductibles and stuff like that, or don't have great pharmaceutical plans, they get stuck with the tablets, and the tablets don't have a good shelf life. They not good to be bounced around, not good to be exposed to sunlight. So now they're having an angina attack, and they take their nitro like they're supposed to, and the pain doesn't go away. So obviously their stress level goes through the roof, and they secrete adrenaline, and their chest pain increases. So now we get there, okay, and maybe the police got there before us and put the patient on some oxygen. So that should help, right? Because it's a mismatch of oxygen. So the more you oxygenate the blood, the more oxygen gets to the myocardium. But they, you know, we give them, we don't have, I'm sorry, I backtrack. We don't have our own nitroglycerin to give them, right? So we're kind of stuck using theirs, and theirs is not potent. So it becomes kind of a vicious cycle, and we wind up having to transport those patients because there's no way of 100% ruling out that they're having an acute myocardial angina versus an acute myocardial infarction. So that's the angina patient. They're told to take nitro 3 times before they call the ambulance at 5-minute intervals, and that's exactly what our dosing would be, is we're allowed to give 3 doses 5 minutes apart. But we'll talk more about nitro in a second. There is a subcategory of angina, or 2 subcategories. One's called Prinzmental angina. That, the story, if the patient tells you they had a sudden onset of chest pain at rest, okay, with no precipitating factor, that could be what's called Prinzmental angina, and that's a spasming of their coronary arteries. If it's the first time, you know, they're not going to know it, but they should know that they have this kind of weird disease, and they may be able to tell it to you, or they may, you know, just say, my doctor, you know, told me I have this condition where my arteries get tight. So that will respond to nitroglycerin, just not as well. Okay, and then there's some people who have what's called unstable angina, or sometimes they say unstable angina, right? Some doctors call it angina, not angina. Unstable angina, all it means is that it's considered a high risk factor for a heart attack. But what it really is that the precipitating factors don't have to be so extensive. So they may say to you, you know, 2 years ago, 3 years ago, I could walk 20 blocks and I had no chest pain. Now I walk 1 block and I get chest pain. So it's just reflecting that there's more blockage in their coronary arteries. And it's considered a high risk for somebody to have a heart attack. You know, just like people have TIAs, what we used to call TIAs, or, you know, mini strokes. It's pretty certain that within 1 year they can have a devastating stroke, and that's why they treat them pretty aggressively with Plavix and other medications. So same thing, people have unstable angina, it's considered a high indication they may have an acute myocardial infarction. Now, what's the difference with an acute myocardial infarction? First of all, it has usually nothing to do with stress, nothing to do with increasing oxygen demand in the heart, nothing. It's basically 99% of the time, it happens at rest. And what basically happens is that I said that there's fat that develops in the inside of your coronary arteries. And that fat gets covered by a protective cap. Like anytime you have something in your body, the body covers it. It doesn't belong there. The body covers it. So, you know, this fat was inside your artery. The body grows a cap over it. Okay. And as long as that cap stays in place, you're not going to have a heart attack. But again, because of stress and inflammatory substances, kind of like we were talking about before with Kawasaki, sometimes that plaque cap ruptures. And when the cap ruptures, the body thinks there's a wound on the inside of the coronary arteries. And you know that platelets are the treatment for bleeding, right? Or treatment for wounds. So there is no bleeding, but there is a perceived wound by the body, and it sends platelets to the artery to cover that perceived wound. And now the platelets don't just stop, right? They keep on sticking and sticking and sticking, and they close off the artery. So where angina is reversible, it's episodic, you know, and stuff like that. Once you have this platelet aggregation, this platelet release, there's no stopping it, right? I mean, it will clog that artery up, and some people it clogs it up in minutes, some people it clogs it up in hours. It depends on, you know, how occluded the artery was to start and how crazy the amount of platelets that are coming. So what's the classic story we hear about somebody having a heart attack? So first of all, most of the times it happens earlier in the day, before lunchtime versus later in the day. Most of the times they were at rest, okay, watching TV, eating breakfast, you know, no stress, no exertion, okay. And it's because they think it's related to a hormone that we have in our body called cortisol. So cortisol is what they call a stress hormone, and its highest levels are when you first wake up in the morning. So that's why they think that it occurs, you know, because of cortisol, and why it occurs in the morning. The other risk factor for having an acute myocardial infarction would be that the blood pressure going through those arteries is high and erodes away the cap over it. Okay, so high blood pressure definitely plays a role. Having in your body what's called chronic inflammatory processes going on. So gingivitis. So if you've been to the dentist, you see they have signs up saying how cleaning your teeth, having your teeth cleaned prevents heart disease. This is exactly why. When you have a chronic infection in your gums, you have higher levels of this cortisol. People have autoimmune diseases like arthritis, drawing a blank on some of them, but you know, different autoimmune diseases, Crohn's disease and stuff like that, they have higher levels of it. Your cortisol levels are higher when you're stressed. So that's why stress definitely plays a role in heart attack, and cold actually plays a role in it. So they kind of, one of the doctors was going through the typical things we hear about heart attacks, like shoveling snow. So he attributes why there's a higher incidence of heart attacks when people shovel snow is that when you shovel snow, your blood pressure is high. And when you're shoveling snow, you're in the cold, so your cortisol levels are high. And those are two things that trigger this plaque rupture that then triggers the platelet release. So the difference again between angina and acute myocardial infarction is one is a temporary mismatch and one is a permanent mismatch until that artery is reopened. And the only way for that artery to be reopened in the heart attack and acute myocardial infarction is by stenting it or having cardiac bypass surgery if it's in a blood vessel that they can't get the stent to. So that's the acute myocardial infarction patient. Okay, and we're going to go through all the meds in a second. So now, just real quick, some other cardiac conditions. So we've all gone on the CHF patient. So what is the difference between a patient with congestive heart failure and a patient with acute pulmonary edema? So to me, the congestive heart failure is a patient who lives with this problem day to day and manages it with medications. Okay, where when they go into acute pulmonary edema, it's overwhelmed them. Now, it could be that they don't know they have congestive heart failure and they have some emergent situation that puts them to acute pulmonary edema. But in both of those situations, an excess of fluid in their body builds up into their alveoli, their air sacs, and they can't breathe because it displaces the ability to have gas exchange, to have oxygen and carbon dioxide exchanged. Why do people have congestive heart failure? Why do people have acute pulmonary edema? So one cause could be that they have left ventricular muscle damage from a heart attack. And you know that the left ventricle pumps out into the aorta. And if the left ventricle cannot pump into the aorta well, fluid will back up into the left atrium. And then if the left atrium fills, it'll back up into the lungs. And then it'll increase the pressure in the blood vessels in the lungs, which will then cause the fluid to spill over into the alveoli. The same thing that could happen if you have problems with the valve between your left atrium and left ventricle, right? So when your left ventricle is squeezing, the valve between the left atrium and the left ventricle should close, and the aortic valve that opens up into the aorta should open, so that when the left ventricle squeezes, blood should only go out into the aorta. If somebody has mitral valve disease, right, that's the valve between your left atrium and your left ventricle, and that valve does not close completely, when the left ventricle squeezes now, they'll have regurgitation of the blood backwards up into the left atrium, and obviously then it'll back up into the lungs. So that could be another reason why they have it. It could be some strange reasons like we talked about, that ARDS, where there's a change in permeability. But the long and short is that it could even be from kidney disease, right? Because the kidneys relieve us of extra fluid. So people have kidney disease, have a problem getting rid of the extra fluid. So again, an older person's heart just can't process all that fluid. So, that's kind of congestive heart failure. Now, in EMT class, you probably learn left-sided versus right-sided. So left-sided is what causes lung problems, acute pulmonary edema. Right-sided causes venous problems. So those are the people that you're going to see with jugular vein distension, people with pedal edema, because the right side of the heart gets the venous blood right from your superior and inferior vena cava. So if the right side can't pump it to the lungs and it starts to back up into your veins, you'll see jugular vein distension in the neck and you'll see pedal edema. And actually you'll see a distended abdomen in people that are real bad. And people could have both. They could have left-sided and right-sided. Okay. Now, what can we do for people who are in congestive heart failure or acute pulmonary edema? So if they're real bad, oxygen always helps, okay? If they're real bad, CPAP may help them, right? So CPAP in acute pulmonary edema is a real lifesaver. We know the problem with CPAP is that it's hard to kind of, when a person's short of breath, it's kind of hard to calm them down enough to get them to accept the mask over their face. But, if you're confident in the use of the device and, you seem like you're on the ball, they may go along with you and let it work. But if not, you would have to, just keep them on a non-rebreather. And then the last condition I put down there is pericarditis, myocarditis, endocarditis. All those itises are infections, inflammations. So it's all the heart. Pericarditis is the sac around the heart. Myocarditis is the muscle itself. Okay, and endocarditis is the inner chambers, like the inner liner of the chambers of the heart. It's impossible for us to differentiate, but you probably know some people who've had this. So when you have an inflammation in your heart, you get chest pain. So a lot of times we think it's a heart attack. And it's very hard to tell the difference. But if somebody has an infectious etiology, they're having a heart attack probably with what looks like a viral or bacterial infection. So they probably have a fever. They're probably telling you that it's been going on for days, okay, and getting progressively worse, which is not common of angina or an acute myocardial infarction. And they'll probably tell you that positionally they feel better when they're kind of leaning forward a little bit, right? Because they're kind of relieving the pressure off the heart by leaning forward. So you know, not to say we wouldn't treat it as an acute myocardial infarction, but if somebody says, you know, I've been febrile for 5 days, I've had this developing chest pain that increases, it feels better when I'm walking around, it feels better when I'm leaning forward, you might want to call medical control and say, you know, this is what we got. Do you want us to skip the nitro and the aspirin and all that stuff and just get them into you? Because they don't need aspirin, they don't need nitro, they don't need any of that stuff. They need antibiotics. So, you know, that could be a situation. Okay, so does anybody have any questions about the different conditions that or have you ever, you know, had a situation with those patients that didn't go well or anything like that? I mean, you know, remember, when you have somebody in acute pulmonary edema, they're impossible to manage because they feel like they're dying, right? They feel like they're drowning, and you can't even get them sometimes to put their legs up on the stretcher. So they're very, very difficult patients to manage. And you've all, those of you, you know, anybody's been doing it long enough, you all had the situation where you tried to put them on a non-rebreather and they ripped it off. And, you know, why was that? So you're trying to give them 100% oxygen, which is what they need, and they rip it off. So the reason why is that they don't have oxygen starvation. They have air starvation. They have air hunger. So they don't know that they need oxygen. They just know that they can't breathe. They have a sensation they feel like they can't breathe. And when you put that non-rebreather, even though it's giving them 100% oxygen, it's not giving them 100% oxygen at any great flow, right? They don't feel it being forced into them. So they just think you're trying to kill them, right? Like, why are you putting something in front of my face when I feel like I can't breathe? So we should then say, well, then CPAP should solve that problem, because when we get the CPAP on them, right, it's that great blast of air every time they open their mouth. The problem again is it's a huge mask, right? And you know, some people are so scared already that when they see you trying to strap this, you know, scuba device over their face, they think you're insane, and they fight you on it, and they, you know, get scared and everything like that. So some people CPAP works well, some people CPAP doesn't work well. It's just a matter of, you know, are we having a problem with the slides? Because I see somebody texted. Did the slides disappear again?
No, they're fine.
Okay. Okay. Anybody having a problem? Because somebody just chatted that there's a problem.
Okay here.
Okay, no problem.
Okay, here.
Okay. So does anybody have any questions about angina, acute myocardial infarction, questions or concerns or anything? Okay. So let's talk about what we will do for these patients. Okay, so from an assessment standpoint, right, if it's a heart problem, most people will have chest pain or pressure, but we do know that there's so when we classify heart attacks, you know, by the 12 lead EKG, we classify by which wall of the heart is involved. So you have an anterior wall, you have the lateral wall, you have a posterior wall, and then the bottom wall that sits above the belly is called the inferior wall. When somebody's having an inferior wall MI, which is statistically a little more common in women, when somebody's having an inferior wall MI, they have more stomach complaints because the bottom wall of your heart sits above your diaphragm, which then sits above your belly. So that's why we always have, you know, we always put in abdominal complaints could be possibly a heart attack, okay? You have your OPQRST that kind of reminds you of the questions you should ask. So the onset, you know, when did it start? What were you doing? Provocation, does anything make it better or worse? Quality, can you describe it to me? In other words, is it a pressure, a pain, you know? And the problem with quality is once you start giving them some of the adjectives, they, you know, they just say yes. Okay, radiation, does it go anywhere? One thing I found is, you know, when I first started doing this, everybody talked about pain radiating to their left arm. I can't remember the last time somebody told me they have pain radiating to their arm, but it is common for people to have pain radiating to their neck, to their jaw, to their back, okay, but not typically to their arms. And the elderly, pain radiation to the jaw is actually a fairly common complaint. Okay, so those are, just remember, you know, for the test also that, you know, people who are having heart attacks do not have to just have chest pain or pressure. It could be in their belly, it could be in their jaw, it could be in their neck, it could be in their back and stuff like that. So that's called, you know, radiation. Severity on a scale of 1 to 10, with 10 being the worst. Okay, tell me how the pain is. And then obviously each time as you treat them, is there any change in the pain? And time, or T, would be, you know, some people say treatment, or some people say how long has it been going on. People who are having heart attacks or angina can have a complaint of shortness of breath. Okay, sometimes it's just a nervousness, but if it's actually, if you listen to their lungs and you see they're going into pulmonary edema, then that would be a much more significant heart attack, because that means their left ventricle is already getting damaged, right? So that would be a, you know, a time to get going. Orthopnea refers to more the CHF patient or the acute pulmonary patient, orthopnea is trouble breathing by position. So these patients, obviously, you find them, even the COPDers, you find them sitting up to sleep, right? Because when they lie down, well, I'm sorry, let's backtrack. When they're sitting up, the fluid is pooled to their lower lobes of their lungs. When they lie down, the fluid then pools over multiple lobes of their lungs. So, or that's all the orthopnea talks about. And again, some of these people, especially when they're in acute pulmonary edema, are so freaked out that by even just lifting their legs to lay on the stretcher or sit on the stretcher, they want their legs dangling down. Because why? When your legs are dangling down, you're pooling fluid in your legs. So there's less fluid then that the heart has to pump. And if the heart has to pump less fluid, there's going to be less fluid, backing up into the lungs. Most of these people are very, very scared. So they get cool, pale, diaphoretic skin because they have adrenal, adrenaline release. So, a cold sweat is never, never, ever normal. Okay. Well, it could be normal. Let's say if you got scared because, I don't know, you got bad news or you almost got into a car accident. But I'm saying a medical patient who says, I don't feel well and breaks out in a cold sweat, that means their sympathetic nervous system was stimulated, and your sympathetic nervous system is only stimulated in emergency situations. So that's your kind of fight or flight one. So somebody who has a cold sweat, that's never, 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 never normal. Okay. Restlessness, anxiety, right? A very common sign and symptom, especially in the elderly patients. It's kind of hard to get any answers out of them. They're very nervous. The feeling of impending doom. So we've all had somebody who, is having a big heart attack or sat home for hours before they called us and they say, I feel like I'm going to die. And sometimes they do, right in front of you and stuff like that. If you ever a patient that, you're suspecting a cardiac arrest and they all of a sudden lose consciousness and lose pulses in front of you, I would do a precordial thump. I would just haul off and punch them dead center in the middle of their chest over their heart, because most of the times when adults go into cardiac arrest, it's a VFib arrest, and a precordial thump is like a mini defibrillation. So while you're waiting to set up the AED, you can sometimes do that precordial thump. If somebody feels like they're going to pass out and you think it's a heart attack, they have what they call cough CPR, where you just encourage the patient to cough, and it actually increases their thoracic pressure and pumps a little more blood, keeps their pressure up so they don't faint. And again, some patients, none of this works on. You may go on a patient who says to you, I have crushing chest pain for 6 hours and I didn't call because I don't have health insurance or because whatever. If they really look like they're going to code, then put the AED pads on them now, right when you're with them, so you don't have to take the time to put it on them when they do code. So if you're really, really, they're diaphoretic, they look horrible, they're ashen, you really think they're going to code, maybe put it on them early. Okay. I mean, the worst is you're going to, waste $100, but if you really think they're going to code, you'll be saving yourself a minute or two, getting it all set up and put on and stuff. And also, if you think that they're, if you're putting it on where they're still conscious, I would do anterior, posterior. I would put one dead center in the middle of their chest and put one behind them, just the kind of way we do with kids. That's the best way to defibrillate every patient. The reason we don't do it a lot of times EMS wise is that the patient's supine and they're big. So, it's hard to roll them and get that pad in that position. But you have a patient who's conscious and talking to you, slap one pad dead center between their nipples and another one, between their shoulder blades. And that electricity, that flow of electricity is now going right through their heart, right? It's not skirting across their heart. It's going from the front to the back. And you probably have a little bit of better success. And the AED will analyze. You don't have to worry. Sometimes people say, oh, if the pads are not in the right position, the AED will not analyze. The AED will only give you check pad placement message if the pads are not firmly adhered to the patient's chest. So if you have a lot of hair or you have a lot of moisture and the pads are not sticking well and there's a lot of artifact, that's when it gives you the check pad placement message. Nausea and vomiting, very common symptoms in the inferior wall MI, which again is more common in women, okay? So just because it's close to the stomach. Fatigue is probably the #1 complaint in the geriatric population, right? So they a lot of times don't experience chest pain. The reason the elderly don't experience a lot of chest pain is that as you get older, you get neuropathies in your nerve endings. I'm not saying that they're not going to have chest pain, but they may not manifest it the same way a 50-year-old does. But they get these neuropathies. So a lot of times the main complaint of an older person is they feel weak, they feel tired. We call it general malaise, or they have fatigue and stuff like that. Also, a common complaint in the diabetic patient, right? Because diabetics also get neuropathies from the poor blood flow through the capillaries of diabetics. So and the bottom there, I have the atypical presentations. So test question, what 3 patients have atypical presentations, don't have normal, we expect a patient having a heart attack to say they're having crushing chest pain. So the 3 that typically don't have it would be women. A lot of times women's indigestion, okay? The other one would be the diabetic patient, okay? And then the last one would be the elderly or geriatric patient, which again tends to present with fatigue. And palpitations would be as if the patient goes into a rapid rhythm. They feel like their heart is pounding, okay, type of situation, which, a lot of times people go into these rapid rhythms and they're not having a heart attack, but they get chest pain because now if their heart is beating real quick, it needs more oxygen and it can't get it because it's beating so fast when somebody's heart rate goes over 150, you have what's called decreased ventricular filling time. So, picture the heart is going out of control. You need a certain pause for the ventricles to fill with blood before the next contraction. And if that heart rate goes to 180, there's such a slight pause that the ventricles are not filling without enough blood. And your left ventricle, pumps right and gives blood right away to your coronary arteries. So if it's not getting enough blood out into the aorta, which then fills the coronary arteries, then you're going to have chest pain because the heart muscle itself is not getting enough oxygenated blood. So that's the typical assessment stuff. Now, what do we do? So again, somebody's scared. They think they're having a heart attack. Seeing a cold sweat on your forehead doesn't help, right, and stuff. So try to, be as calm as you can. Make them comfortable, right? So, if you may have to loosen somebody's belt and stuff like that, but make them as comfortable as possible. This way, you have less adrenaline release, okay? Now, oxygen in a heart attack. So for years, we said that, since most heart attacks are that anaerobic metabolism where there's not enough oxygen getting to the heart, we should give them high concentration oxygen. A lot of studies say that doing that is detrimental, okay? They talk about oxygen toxicity and free oxygen radicals, and that when somebody has a normal O2 sat, which is defined as 94% or higher, and they get high concentration oxygen, by study, it seems like they have a worse outcome. So because of that, we don't give high concentration oxygen to heart attack patients if they have a normal pulse oximetry. So again, 94% or higher, okay, we can defer oxygen. I would not give it to them, but I would probably give them a liter or 2 of nasal. This way it looks like, you're still doing something and there's some psychological component to it. And obviously from a documentation standpoint, your document, you gave them some oxygen. But, if they're 94% or less, technically, they don't need oxygen. Okay, and the protocol was adjusted. For years we had to give oxygen to every patient, but the protocol now says oxygen is appropriate. So in this situation, it wouldn't be appropriate if somebody's satting, 95, 94, 95 and above. I wouldn't give it to them unless they tell you that I feel like I can't catch my breath. Then, you document that the patient, stated they couldn't catch their breath, and you could still give them oxygen. The next one, and this is the one that you're probably going to be giving first in most situations because most people's pulse oxes are normal, would be aspirin, okay? So we know that it has to be non-enterically coated chewable baby aspirin. So that is the 81 milligram baby aspirin. Now, the issue is when you go to Costco and buy non-enterically, Costco and buy children's aspirin or even CVS, it's the aspirin that people are told to take 1 a day to prevent them from having a heart attack or to help them with their cardiac disease. That is coated. The reason it's coated is they don't want it to dissolve in their stomach. They want it to dissolve in their intestine so that there's less bleeding problems. That is not of any help in somebody having a heart attack. You have to buy the non-enterically coated version, the St. Joseph's chewable baby aspirin, non-enterically coated, ones. So there should be no hard yellow coating, no hard green coating over it. And for a very simple reason, if somebody's having a heart attack, you want that aspirin to go to work immediately and raise their therapeutic level immediately, not 3 hours down the road. So now if that's all you have, then you just tell them to chew it up, grind it up with their teeth as best they can. It's not going to be ideal, but that's all you can really do in that situation. Again, they're going to take 481 milligram, 324, chew it and swallow it. Make sure you tell them before you put it in their mouth, they need to chew it and swallow it because people will routinely just swallow anything you put in their mouth. It's not common to chew medication. And obviously, it doesn't taste that great. So, you have to have it. Now, the protocol says that if a patient took aspirin before we got there, that we could not give them our aspirin. But it says specifically only if you're 100% certain they took the right dose, the right way, and that the aspirin was still potent. So how do we know aspirin is potent? You know, we have no way of knowing. So that would be go by expiration date. So if it's expired aspirin they're taking, you would give them your complete 324. If they told you that they took a coated aspirin and swallowed it, you're going to give them your aspirin and tell them to chew it and swallow it, because the coated one is not going to kick in till hours later. And again, don't fear it, because even if theirs kicks in and yours kicks in, it's still less than, it's still the 650, right? Which is, again, the amount they took when they had a toothache. So if you have any doubt, you know, oh, and then the last thing is, you know, you have people take Tylenol, right? They think it's aspirin, so they'll take Tylenol. So again, you give them your aspirin. So if there's any doubt, you're going to give them aspirin. And the reason is very simple. Aspirin is the drug that saves people's lives who are having heart attacks. We said the problem in a heart attack is that the platelets are clumping and closing the artery. Aspirin interferes with that, stops that process. So the quicker you give them the aspirin, the less blockage they're going to have in their arteries, and the better they're going to do. There is no, somebody asked, is there an age limit for aspirin or anything? In the city protocol years ago, there was, but in the New York State protocol, there is no age. You know, I mean, it would be rare to have a pediatric patient that you think is having a heart attack, although now we have this Kawasaki. But, you know, but there is no age. Actually, there's no age on any of our medications anymore, because the other one that was a big one was albuterol, right? They had to be between the ages of 1 and 65 and have a previously diagnosed history of asthma. But they took it all out now, you know, so the new rule for albuterol is if the patient's wheezing, they can have albuterol, and they raised the dosing of albuterol from 2 doses to 3. So aspirin has no, the only contraindication to aspirin would be a history of anaphylaxis. If they tell you that they had a previous GI bleed, that is not a contraindication. If they tell you that they're having a heart attack and a GI bleed at the same time, that would probably be a contraindication. So if you ever like have some concerns about aspirin in the setting of a heart attack, you can always call medical control and run it by them to see, you know, what they want to do for you, you know, what they want you to do for that patient. Okay, hold on one second. Somebody else has a question. I don't know why I'm having problems with this tonight. Okay, let's see. Oh, okay, you're welcome. So if you guys have questions, I'm sure, you know, other people probably have similar questions, so just unmute yourself. It's easier than me trying to get the chat to work, the chat feature to work, okay? So again, the only ones that would not get aspirin in the setting of a heart attack would be people who have a history of anaphylaxis to aspirin, not just that they had some previous bleeding in the past. And the other one I would, you know, say probably not to give it to is somebody who has an active GI bleed and a heart attack at the same time. Okay, now the other medication that we're allowed to administer to a patient would be nitroglycerin. So again, this is not something we carry on the ambulance. This is something that the patient would have. So if the patient has nitroglycerin, they obviously have a diagnosis of angina pectoris. That's why they would give it to them. So the nitroglycerin that we're giving to them is really, we're assisting them with taking their own nitroglycerin. So there is some parameters. Now, nitro is a drug we really can screw somebody up with. So the first thing is we want to make sure they're hemodynamically stable and they have an adequate blood pressure. So they make the blood pressure that an EMT has to look for 120 millimeters of mercury systolic. Most places would say 100, so you're way covered with 120. Okay, so you want to see a systolic of 120. Okay, the other big things relate to medication interactions or medical or types of heart attacks they may be having. So the erectile dysfunction medications, the sildenafil that's in the erectile dysfunction medications in Viagra, Cialis, and Levitra, that medication was being originally tested as a blood pressure reducing medication, right? So they knew right off the bat that it relaxed blood vessels, and they were seeing if that would work to control blood pressure. And obviously in the study, the male patients reported that it was easier for them to get erections, and that was the end of it being used for a blood pressure medication because they made more money selling it as a erectile dysfunction medication. So because it has that property of lowering blood pressures, and because nitro has a ability to relax blood vessels and lower blood pressure, you now have 2 medications that do the same thing. And when 2 medications do the same thing, it's called potentiation. They both work better. So there is a risk when you take ED medications and nitroglycerin that you can drop your blood pressure. Now, I know if you listen to the protocol update that they said not to worry about that anymore. So I actually wrote them a letter and said, you're wrong. And they brought it up to the CMAC, and the CMAC told them to send something out saying they were wrong, which they worded it very, vanilla. But you should not be giving nitro to somebody who's taken Viagra, Cialis, and Levitra in the last 72 hours. In all honesty, it should probably say the last 24 hours, but again, the state always goes towards the side of caution, so they made it 72 hours. But most of us, 24 hours, that drug is out of our system. Okay, so you don't have to really worry about it. There is a Cialis that it's an extended release. They say like you can take it on Friday, it covers you for the whole weekend. So that one I would probably wait the 48 hours. But Viagra is out of your system in like 8 hours. Levitra definitely in a day. Cialis again probably be a day unless you're taking the extended release one. So the only reason you're doing it is that the ED medications will potentiate the effect of the nitroglycerin, and it's more likely you're going to cause the patient to faint and syncopize. And you don't want to drop somebody's blood pressure who's having a heart attack, because then there's going to be less blood getting to the myocardium, and they're going to just have a bigger heart attack. So in saying all of that, you would say to me, the only patient I have to worry about as far as ED medications would be men. And that was true up until about 5 or 6 years ago. But sildenafil now is being used to treat other conditions besides erectile dysfunction. It's being used to treat BPH, where the prostate gland in a man gets enlarged, but it's not cancerous. And they have problems with steady stream urination, they spurt. So it's one of the drugs that they can use. Most of the times they put them on an alpha blocker. I'll show you some different names of them in a second. But again, it could be used for bad PPH. So I would say if you're going to give nitro to people, you want to say, one, are you taking any drugs like Viagra, Cialis, and Levitra recently? Also, do you have a condition of BPH? And if so, what medications are you taking? And the last thing is a condition that can affect women and men. And it's called long pulmonary hypertension. So high blood pressure in the blood vessels in the lungs. So it's not high blood pressure through the whole body. It's pulmonary hypertension in the blood vessels that are bringing blood from the right side of the heart to the lungs. And that could happen to COPDers because their lungs become stiff because of the disease. Could also happen for no reason, and it does in a small amount happen to young healthy women, sometimes around the time of pregnancy, and it's called idiopathic pulmonary hypertension, where all of a sudden they can't catch their breath and they can't figure out what's going on. Their chest x-ray is fine, their chest CT scan is fine, and then they start looking at pressures in their blood vessels and they find they've developed high blood pressure. Nothing they did wrong, right? They develop high blood pressure and the blood vessels going from the right side of the heart to the lungs. So that means that the right side is now struggling to pump the deoxygenated blood to the lungs, and the patient gets a sensation of shortness of breath. The long-term consequences are they're going to get right-sided ventricular hypertrophy, because that right side is going to fail because it's struggling all the time to pump. So what they do is they give them medications, and I think it's called Revidio. It's not called sildenafil when it's in there, but the active ingredient it's called Revidio. What happens is it relaxes those blood vessels that have the high blood pressure, okay, and it's easier for the right side to pump, and it makes them, manageable. Okay, so in all of those situations, if they were actually having a heart attack and they had a prescription for nitroglycerin for some reason, then it would be contraindicated. Now, I would think most doctors, if they put those patients on these types of medications, they would probably then tell them not to take nitro, so they would no longer have the nitroglycerin. So Artie, my dog's signaling it's almost time, so I'm going to speed it up a little bit. So we'll get out of here. Okay, so what are you allowed to do? You're allowed to give up to 3 doses of nitro, 5 minutes apart, as long as their systolic blood pressure stays over 120. How do you know the nitro is still potent? So everybody told me in one of the previous classes, they know that if it's the tablet, that the patient will feel a tingling or burning sensation under their tongue. And most patients get a little bit of a headache. The spray doesn't always give you the tingling or burning sensation under the tongue, but should also give you the headache. So that's how you know the nitro is still good. Okay, what else? So if you gave the first dose, it doesn't work. You're going to wait 5 minutes, give the second dose. Obviously, you don't have to stay on the scene. You could start transporting. You can give up to 3 doses. I've not had an angina patient that continued to have chest pain after 1 dose. They immediately start telling you they feel better, and so on. So I can't remember the last time I gave more than 1 dose of nitroglycerin. Okay, and all those patients who you suspect having heart attacks, this is another test question, right? Where should a patient who you're suspecting having a heart attack go to? And that is a hospital that can do angioplasty. So if they cannot do emergency angioplasty, right? Most hospitals can do angioplasty. It's a question if they could do emergency angioplasty. All you're doing is delaying that patient's treatment, because they're going to have to be retransferred out from the hospital you take them to the angioplasty center, and you're going to increase their costs because they're going to have to pay for another ambulance ride and stuff like that. So they definitely, somebody you suspect having it. Now, I'm sure somebody says, how do I tell the difference between angina and a heart attack? Or should I even tell the difference between angina and a heart attack? So yes, you probably could tell a difference. Would you be 100% certain? No. But if you relieve their pain, they're probably not having a heart attack because you're not doing angioplasty in the field. So if you treat somebody with oxygen, rest, and nitroglycerin and their pain goes away, it's probably more of an angina attack, especially if the story was that they were doing some stressful event when the chest pain occurred. Now, could nitroglycerin take the edge off a heart attack pain? And the answer could be yes, it could, but it's not going to relieve it. And the one type of patient where it kind of takes the edge off of it is the older patient who has the collateral circulation. When we give nitro to someone who's having a heart attack, it's not going to open up the clogged vessel. But what it is going to do is it's going to dilate the collaterals that developed, right? We talked about the older people having collaterals. So you would suspect in an older patient, if you gave them nitro, they may say that, you know, the pain got a little better. It didn't go away, but it got a little better. You wouldn't suspect that in a younger patient because, again, they don't have the collaterals. Okay, so again, aspirin is the most important drug. It prevents that platelet aggregation or clumping that occurs when the plaque ruptures. It should be given to every patient who suspect having acute myocardial infarction. The contraindication would be allergies to aspirin, okay, solicitates, you know, aspirin type of medications, or a history of an active GI bleed at the time you're treating them for the MI, okay? Now this is showing you in a gross exaggeration what happens. So this is the coronary artery, okay, and that they had this plaque deposit that developed. And the body, again, grew this cap over it. That's these little cells over here, okay? And for some reason, the plaque deposit ruptured, okay? Now the body thinks it's a wound, and the platelets come and clog it up. But they don't just stop clogging up the wound per se. They keep on sticking together, and eventually they're going to close off this artery. So if somebody had a heart attack, felt chest pain, and took aspirin immediately, they probably wouldn't really have a massive heart attack. So every minute that they delay taking the aspirin, okay, there's more platelet aggregation, there's more narrowing. So if this artery was very narrow, if this lumen was very narrow, it could be quickly closed off and they could be having a massive heart attack. So it just depends on how narrow it was to start with, how long it took them to take aspirin, and so on. And be honest with you, you know, every one of us should have aspirin at home. You know, I mean, I freely admit mine's a few years old, but you know, we should have aspirin at home, because if we're having a heart attack, we don't want to wait for the ambulance to come and give us aspirin. We want to take it immediately. And you know, the other thing you would have to consider, and I know where you guys, it's not a long response, but you know, let's say you have a country house, you're upstate, and you know there's nobody coming for you. Well, if you're having a heart attack, you should probably chew your aspirin and get in the car and either have somebody drive you or drive yourself to the hospital. Especially, you know, if it's going to take a 45 minutes for the ambulance to get to you, you would want to be on your way to the angioplasty center, you know, because time is muscle. You know, I mean, you don't want to delay it. I mean, obviously, if you could have somebody else drive you, that would be better, but you definitely don't want to delay sitting home waiting for somebody who may not be coming. Okay, so the route is oral. Make sure you tell them to chew it and swallow it. Okay, and again, New York State is 481 milligram, 324. Nitro, we said, is a smooth muscle relaxant, non-selective. Okay, so it is going to relax every smooth muscle in your body, but we're doing it for its ability to relax the blood vessels in the coronary arteries. And when somebody's having an angina type of attack, to get more blood. And again, there's no harm in it in somebody having a heart attack, but it just may not help in all situations. Okay. So contraindications. I put allergies to nitroglycerin because it's one of the things in the protocol, but I've never, ever, ever, ever had anybody tell me I have an allergy to nitroglycerin. I've had people tell me they don't like the way it makes them feel. But again, you probably are not going to have an allergy to nitroglycerin. You can have an allergy, I'm sure, to preservatives, but not to the nitroglycerin itself. Okay. Their blood pressure. Okay. I said, contraindications. I'm sorry. Blood pressure below 120. I thought it should actually be blood pressure above 120 is what's right. They have to have a blood pressure above 120, but a contraindication would be if their blood pressure is below 120. And then I wrote the suspected inferior wall MI. So again, the inferior wall MI is the bottom wall of the heart, sits above your belly. Those people have more GI symptoms, indigestion, belching, abdominal pain. And the reason why is, okay, that the right descending, let me do this, the right descending coronary artery, okay, comes down across your right ventricle, a right atrium, right ventricle, okay, and then wraps around the bottom wall of your heart, your inferior wall. So if you block it down low, then somebody just has a problem with blood flow to the bottom wall of their heart. But most times when it gets blocked high up where it starts. So they have what's called an inferior wall MI with right ventricular extension, right? Because it's going to wrap around the right ventricle. So now the right ventricle is not getting enough blood flow to stay alive. If you give them nitro, okay, you have two problems. You reduce the venous return, which is what the right side gets, okay, right? Because the right side gets the inferior and superior and vena cava blood. And now the right side can't pump with a lot of strength. And what tends to happen when you give inferior wall MIs nitroglycerin is they get real sick. They get really bad. They drop their pressure. They get bradycardic. So as a general rule, if you go to somebody's house and there's no ALS, okay, because there's no way for you to tell BLS that they're truly having an inferior wall MI besides signs and symptoms. On an ALS standpoint, when they do a 12 lead EKG, they would see ST elevation leads 2, 3 in AVF, and they would know it. But you would just go by signs and symptoms. So again, somebody who has more GI signs and symptoms, I would stay away from nitro. I would not give them nitroglycerin. Even if their blood pressure was 150, I would still stay away from it. Because it can cause a precipitative drop in their blood pressure and really screw things up. I never, ever give nitroglycerin to inferior wall MIs, even if they were hypertensive. If they had a blood pressure 180, I wouldn't give it to them. Okay, just if they want to do it in the hospital, you let them do it in the hospital. But so the three big ones, again, I'm sorry, the two big ones would be the three big ones would be the ED medications, the blood pressure below 120, and the suspected inferior wall MI. Don't give them nitro in those situations. Okay. So we talked about the ED medications. We talked about that they may have it for BPH and the pulmonary hypertension. And then the other thing I put in here, and this is not really something like the state talks about or anything like that, but when people have prostate problems, BPH, right? The most common initial treatment are what they call alpha blockers. So the Flomax, the Tamalosin, is the most common medication that's out there for BPH. So alpha blockers can also drop blood pressure, right? So it's not that it's going to interact with the nitro the way that the other drugs do, but it's going to cause somebody to have a little bit of a lower blood pressure. So nitro is also going to drop somebody's blood pressure. So this would be another situation where if somebody's taking any of the medications here and stuff that are, common alpha blockers, and alpha blockers can be used for blood pressure control too. But if they're taking any of those, I probably would hold off on the nitro. So if somebody says they have a history of BPH that's being treated by medication, I would probably stay away from the nitroglycerin with them because you can, again, give them the nitro and drop their blood pressure. Now, in saying that, what do you do? So you gave somebody nitroglycerin and they pass out. Like, what do you do for them? So, the first thing you want to make sure is, are they alive or dead? So do you go to check a pulse or do you lay them down first? So I would say you have a better chance of finding a pulse if you lay them down, right? So if you gave them nitro and they were semi-recumbent on the stretcher and they all of a sudden passed out, the first thing I would do is lay them down and elevate their legs. Then I check for a pulse, okay? Because if you try to find a pulse when they're sitting up, they may have a pulse, but it's just not perfusing well because of the fact they're in an upright position. So you give somebody nitro, they bottom out, their blood pressure, they pass out, okay? I would lay them flat, elevate their legs, check for a pulse. It's going to be hard probably to find a pulse if you bottom out their blood pressure. So the other thing I would do is take my stethoscope and listen for their apical pulse of their chest, right? So put it right, where the heart is and listen to see if you hear a clicking, a tapping noise. If you do, their heart's beating, okay? So if they don't have a pulse, then obviously you're treating them as a cardiac arrest. You're going to start CPR, okay? But if they do have a pulse, I would, again, have them supine, check for a pulse. I would put them on some oxygen, keep their legs elevated, and they should slowly start coming around as the nitro starts to wear off. Okay, I mean, it's going to be a high sphincter control situation for you, right? And also for them. But I never ever give nitroglycerin to people unless they're on the stretcher and their legs are up. And I always put them semi-recumbent, not sitting straight up. Okay, and especially if they tell me they haven't taken nitro ever before, or that they haven't taken nitro in a while. And then I probably would lean them, I wouldn't say totally flat, but I would lean them back, a little lower than semi-recumbent on the stretcher. Because if any one of us took nitroglycerin right now, I guarantee you that we would have the worst headache of our lives and feel dizzy and weak and couldn't sit up. We had an EMT who got nitro paste on his hand, his ungloved hand. The medic called him to go from the front to the back. So he crawled through that little hatch in a van ambulance. I don't know how he fit, to help him. And then the medic said the patient had a bad response to the nitroglycerin paste. So the medic was wiping it off on a 4x4, and he handed the 4x4 to the kid and said, throw it away, that had the nitro on it. The kid just grabbed it. He turned around to start walking back to the driver's seat and passed out headfirst into the wall and wound up with a concussion. So now all of a sudden on the radio, the medic's screaming for help. He's got a patient with chest pain who's probably having more chest pain now because of this, the whole thing happened. So we had to have 2 ambulances respond. It was a disaster, you know. So, I mean, it took literally, I don't know, 30 seconds for the kid to pass out. So that's exactly what happened with all of us, you know, if we took nitro for the first time. So we have to be very, very careful to keep them supine. This kid obviously was standing up, which is why, you know, he couldn't get enough blood pressure to his brain with the nitro, and that's why he passed out. Okay, so we said you're allowed to give up to 3 doses 5 minutes apart as long as their blood pressure stays above 120. We know it's sublingual, under the tongue. That in itself can be a chore, right? Especially in some patients, to get them to lift their tongue to get it under there. So if you have to help them with that, the only way you could grab a tongue, and you're going to have gloves on, but the only way you can grab a tongue to lift it is with a 4x4. So, you know, have them stick their tongue out and then just grab it with the 4x4 and lift it up to be able to spray it underneath. And you probably, if you've been to it, if your dentist is good, you probably, when you were with your dentist, saw that nowadays they're supposed to check for buccal cancer and, you know, and tongue cancer and all this stuff, especially in people that chew tobacco. So they're supposed to check and lift your tongue and look underneath it for any signs of cancerous lesions and stuff. So that you probably saw them grab your tongue that way with the 4x4. But that's the only way you can get the tongue up out of the way. It'll just slip with gloves on.
Hey,
Okay.
Frank,
Yep.
is the nitro, the spray sublingual too?
The spray is sublingual too, yes. All nitro is sublingual. I should
Okay.
say all nitro that you're going to be able to give. I mean, there is intravenous nitroglycerin, there is nitro paste, but you're going to be giving just sublingual nitroglycerin. And it will go to work immediately. Your buccal beds, your sublingual beds are very well perfused. So, you know, as soon as you give somebody nitroglycerin, they're going to feel that slight tingling in their head, I would say within a minute, you know, without a doubt, within a minute.
Back on the aspirin.
Mhm.
What about you know, you've got a patient in their 60s or so that takes a blood thinner like Xarelto or Eliquis or Pradaxa.
Doesn't matter. Yep.
You're still going to give the aspirin. Yep.
Yep. You're still going to give the aspirin, because one, if those medications were, you know, going to work, they would have probably prevented the whole situation from occurring, and there wouldn't be any platelet blocking. But yeah, there's the only time the state protocol says to defer aspirin would be is if they took their own aspirin since they had the symptoms and they took it the right way and it wasn't expired or anything like that. So yes, you would definitely still give it to them.
Okay, thanks, Frank.
Okay, does anybody have any questions on the angina, the heart attack, the congestive heart failure, pulmonary edema, the myocarditis, pericarditis, or anything like that? Okay, so the only last thing we talked briefly about the albuterol. Is this the albuterol you carry? Is this the way it looks? Yes, no? No?
Yes, Frank.
Yes,
It is?
Frank.
Okay,
Yes.
so that
Yes.
one's fine. That says albuterol on it. Let me just see if I could find. It's just going to have meter dose inhaler. No, I can't find it. I'll bring it the next time we actually have a live class, or next time we do a Zoom, I'll find a picture of it. Because that way you're carrying the albuterol, it's labeled. There's a blue label on it, so you won't have an issue. But the one I was talking about, I can't find a picture of. Okay, does anybody have any questions? What time is it? 9:06, so hour and a half, right on time. Anybody have any questions? Okay, so I sent the, what's that?
Albuterol,
Yes,
or
yes.
excuse me, Narcan.
Narcan.
Okay, the 0.4s that we use.
You shouldn't be using
There's
0.4s.
is it
You're using 4 milligram.
4
The ones-
milligram? Yes, I'm sorry.
free-
4
the free,
4 milligram.
the free ones from the region?
Yes.
Yes, so those are 4 milligrams, but the available, so it's 4 milligrams in there, but the amount available for absorption is 2 milligrams. So in other words, there's such a tiny amount of fluid that contains that 4 milligrams that they say the patient really only absorbs 2 milligrams. So it's the exact same when you used to screw it all together.
Right. So you're allowed a second dose on this?
Yes.
All right, because we've gone into the hospital at times and they've telling us we're giving them too much Narcan.
So the problem with that, I'll tell you, is that you're not waiting. Let's put it this way: when you show up at the hospital, is the patient awake?
I had yeah. I mean, we've
Okay.
had yeah.
Okay, so this is something, the same problem we have here. We mainly have it with the police officers. So when the cops give Narcan and they have a quote save, they get an award. So when we have an overdose, there's like 10 cops showing up, and they're each giving, they have 2. So the patient's getting 20 milligrams of Narcan. And they're actually in withdrawal at this point because they're so blocked. So the problem is nobody's waiting. So really, when you spray the Narcan up their nose, you should probably wait a minute or 2 before you give the second one. And
Well, we had an example, Frank, where we had PD on scene, and you know, they were approaching the patient the right way. You know, the patient had a lot of mucus,
okay,
nasal mucus, a tremendous amount, and it was still, it was still coming out. You know, they did give 2 doses. They spaced them out, but they gave 2 doses, and my impression was it wasn't being effective because of the blockage. Now, I gave a 3rd dose once I cleaned his nasal passages out because this guy wasn't responsive.
Right.
And the 3rd dose, the person was talking to me going in the ER.
Okay, so what was their complaint?
So,
Was he
well, then
combative?
I had given 12. No, I had given too much, and I should have stopped at 2.
Well, first of all, you have to explain to them, you know, again, even though it says 4 milligrams, if they read the medication insert, what they call the term, it's called bioavailability. So the bioavailability is 2 milligrams. So you're not giving, you didn't give them, you gave them 6. And then, well, again, if they were willing to listen, the fact that the police officers gave the first 2 doses to a nose that was covered with mucus means that those were not properly absorbed. So I don't think you did anything, you know, wrong. It's just, you got to understand.
Yeah, I was just trying to, you know, again, because, you know, you've got to talk to the ER. I mean, these guys did the great job. I mean, it was a very confined space. They were able to get to him. He had the potential of aspirating, and but we got him cleaned up in the rig, and we were able to get a recovery out of it. But you know, sometimes trying to talk to the ER nurses and doctors can be a challenge.
Oh yeah. I mean, not that I would advocate, but when they really are mean and nasty to us, we tend to go to, you know, Spring Valley and pick up the drunks and bring them all night to the emergency room, and tends to mellow out their attitude. But you know, no, it's a hard thing, and you know, nobody knows the other person's job. And obviously, I'll tell you what happens in the emergency department is that patient's not going to want to be there. So in their mind, we should have just left the patient, you know, at the scene. So they're just like, you know, you bring a patient in, they're not going to stay, but yet we have to do all this stuff that we have to do before we can discharge them, and it's just a headache. So
now you get somebody that's been given, you know, a lot of Narcan. Do they have to watch them for a period of time before they release them?
they don't watch them. As soon as if the patient's conscious, alert, and oriented, and says, "I want to go home," they're going to do the paperwork and get them out. You know, I mean,
I had one of them tell me they were going to have to send the patient. They might have to send the patient out because they had too much Narcan.
No.
Which you know, like I said, I don't know where it's coming from.
There is literature on patients that get a lot of Narcan go into what's called a hyperdynamic state and go into pulmonary edema. Because when they're so go into such a severe withdrawal, they have a catecholamine release, and they tend to go into pulmonary edema. But again, there's no way what you did to that patient is going to cause that. I mean, there is fear of, like, let's say, I don't know, let's say you had a newborn that was born to an opioid addicted mother, right? So you have a newborn born to an opioid addicted mother. At birth, the baby's breathing 10 times a minute, right? So technically that baby needs Narcan. You can't give intranasal Narcan because, you know, you're stuck with that 4 mg/2 mg Narcan. But let's say the paramedics come, I don't know, it's a long I mean, personally, I would just transport that kid and bag him. But let's say you get some, you know, young, aggressive paramedic, and he decides he's going to start an IO and give this kid, I think it's 0.02 mg/kg of Narcan. Let's say he overshoots it. He could throw that kid into a massive withdrawal now, right? Because that kid was used to growing up in this high opioid environment, and now he overdosed him on the Narcan. He throws him into withdrawal. That kid could have seizures, could stop breathing, could have like a lot of funky stuff happen. So I'm sure technically the same thing could happen to an adult if they were very rapidly reversed, but it doesn't happen with intranasal. That's IV Narcan. You know, like, it's very rare you're ever going to see those types of situations with intranasal Narcan. So I think it's just, you know, lack of information on the part of the emergency department, or, you know, I mean, that's something really where you probably should, you know, make a meeting with your medical director and say, hey, you know, like, we're getting this feedback. Here's some literature we found. You know, it doesn't seem to be supporting what they're saying. You know, here's the situation, which we tried to verbalize to them, where, you know, the police officers gave Narcan before we got there, but it was probably not absorbed. So the patient really only got 1 dose of Narcan. And even though the thing says 4 mg, it's really 2 mg. You know, it's just probably just lack of information on their part.
Okay, thanks, Frank.
It's not that you definitely didn't do anything wrong with the patient. So.
No, thank you.
Okay, does anybody have anything else? Okay, so it was nice seeing those of you that I saw, and I guess we can try again next month. So, like, this is kind of a work in progress, so definitely feedback would be great. You know, if you have any suggestions on how to make it better or worse, not worse, obviously, better or easier and stuff. And you know, what's that? I thought somebody said something. And
For the Warwick guys, it's Frank on here.
okay,
Cassanite. For the Warwick guys, I know Joanne and Jackie are on the call, but anybody else, just text me that you were on the call so I can give you credit. That's all for now.
okay. And then you should be getting.
Same thing for Greenwood Lake.
Okay. So you should be getting an email from somebody in your organization that, you know, with the link to the test. If for some reason it doesn't work out, then just somebody text me or call me or something, and I'll resend it out. But I know Kelly told me she got it, so I would think that I sent it to Mike, Eileen, Frank, Engel, you know, so I sent it to
I have a link to
Harrison.
the test, so I'll send it to the Warwick guys.
Okay. So everybody should have it. And other than that, you know, we're done. If anybody has no other questions. Oh, and I'll also send out, so once this finishes converting, it'll be up on my YouTube channel. So I'll send a link to the same people I sent the link to the test for. So anybody, you know, and there's a whole bunch of other lectures up there and stuff like that. If anybody, you know, you have some free time and you want to look at anything else. And if you have any suggestions of what you want to do in the future, you know, obviously just pass it on and I'll be happy to work on it. Okay. So everybody have a good night. Have a good weekend. Stay safe.
Thank you, Frank.
Take
Thank you,
care.
Frank.
Thanks,
welcome.
Frank.
Take care.
Thank
Bye-bye.
you.
That's right.
Take care.
Thank you.
Thank you. Holly, I'm sending you the link.
Okay, Nancy, I took attendance for us.